All right, welcome back to the PMR podcast. My name is Mitch. I'm an addict alcoholic, and today we have a very special guest. He's a good friend of mine. I went to Denison University with him. We swam together for I was there for 5 years, but I swam with him for three of them. And he's a great, great friend and a very impressive friend. He had a health and exercise and sports science degree at Denison, and then quickly moved into the United States military, where he is completing a medical degree at Des Moines University. We'd like to welcome Peyton Gaumer to the episode.
Pleased to be here.
Thank you. Super excited to have you on. This is episode 22. And yeah, we've been talking for a while. I know you had hit me up. You've consistently been supportive of me in my recovery, and I wanted to thank you for that sincerely. And as well, on top of that, you have been interested in learning more. And when I saw you last, we had a long conversation about some of the stuff that I was doing and recovery related things. You know, you and your wife are both have been getting after it in terms of getting into the fields that you want to be in. And yeah, I mean, I was just thinking a couple of months ago, I was like, I think we should have him on. And then we started having a conversation a couple of weeks ago. So yeah, I'm excited to get into it today. And I know we have a lot to talk about.
Sweet. Glad to be here. And it's actually interesting. The medical field I decided to go into is called physical medicine and rehabilitation, PMR. And if you actually Google PMR podcast, what you actually get is a bunch of like medical podcasts in my field of medicine, and then you get you.
That's funny. Yeah, I know. I've had some people hit me up when you Google the podcast. It actually cues a hotline at the top of for an addiction hotline as well, which is pretty cool that you get. If you really needed it, you got the super help up top, and then maybe something that might help with us below. But I wanted to hear from you. What have you been up to since graduating Denison, since swimming has ended and all that, and tell me a little bit about what's going on.
Yeah, so I'm in my last couple of months of medical school. I've had a full ride military scholarship to Des Moines University Medical School. So the way that works is that you get commissioned as a lieutenant when you start medical school, and then you do 2 summers of basic training. Did my first one in Fort Sill, Oklahoma, summer of 2020. 2 summers later, I did my second summer at Fort Sam Houston in Texas. And then you also complete a bunch of rotations in different military hospitals while you're trying to figure out what specialty you want to go into. So I've been at Fort Belvoir, Virginia, at Walter Reed, and at Brooke Army Medical Center, which is at Fort Sam Houston in Texas. So I've done month-long rotations in all three of those places. And ultimately I was selected for, as I said earlier, physical medicine and rehabilitation at Walter Reed in Bethesda, Maryland, where I'll be starting in just a couple months. So what we do is like we treat, it's like the musculoskeletal system, the nervous system. So that includes like chronic pain, acute pain, but also like burns, spinal cord injuries, amputees, traumatic brain injuries, like acute orthopedic injuries, joint problems, any sort of those like wide variety of things. And I think that's kind of like where the intersection between kind of like what we wanted to talk about today is that a lot of people that are in addiction come into it having dealt with some sort of pain in their life, whether it's physical pain or whether it's emotional, mental pain. And kind of getting on top of that can be really useful for those people.
Yeah, I agree. I think it's really interesting that you're getting into that and you're getting access to those opioids, which is used to be a friend of mine and now my mortal enemy. It's like it's a tough, it's a really tough thing because obviously people have, like you were saying, extreme pain for certain things, and on top of that, past traumas and exposure to things that may lead them to not be the best candidate for opioids for their pain. And so it gets into a sticky situation of like, how do you handle that? You know what I mean? So I wanted to ask you, like, in terms of In terms of from what you've seen and what you can say on it, like how do you feel? Like, what's your comfortability level with when you're handling those sort of controlled drugs?
So I think the problem is, so I mean, the short answer to your question is most people in my medical specialty seldom use them. We don't, because there's a lot better ways to treat pain, right? So there are good uses for opioids, short term after surgery, cancer care, end of life type things. But really, those drugs are, I mean, they work, but they're highly addictive and they're not something that people should be on for a long time. And I think that if you're going through medical school, unless you are going into some sort of like specialized training field like I am, or maybe orthopedics, anesthesia, something like that, a lot of people don't get a ton of training in how to manage both like acute and chronic pain. Did you watch that like documentary Dope Sick on Hulu?
I did, yes.
Yeah. So like that's actually like a pretty good example of how a lot of that worked. If you notice that most of those people that were getting hooked on the opioids, they were getting prescribed by like good, well-meaning family medicine physicians um, who basically got like duped by the pharma companies into thinking like this is safe, this is something that people should be on long term, and it's totally safe, whatever. Turns out that wasn't the case, and a lot of people that were dealing with real problems ended up hooked on opioids, kind of going down the rabbit hole, some of them into heroin, fentanyl, worse things. I mean, if you look at before OxyContin, there really wasn't as big, not nearly as big of an opioid problem in the United States, but now it's kind of like out of the rabbit hole. But
Hmm.
we try to use different methods to work on the pain, like, right? So opioids block everything, right? They're going to block every pain, like every pain signal in the entire body is going to be numbed by opiates. But if you a better approach to it is to figure out like exactly what's causing the pain and to just get rid of it, right? If it's physical pain, you can do that. If it's emotional pain, I mean that's a harder problem. But
Right.
I mean, if someone's got back pain, you can actually like go in there and you can find the nerve under ultrasound that's causing it, and you can just like put some lidocaine in there, and then if the pain goes away, then you know you found the right nerve, and then you can go in like a week later, and you can do what's called like a radio frequency ablation, just gets rid of it. They don't have any more pain, and then you don't need to use a drug like that. You can do all sorts of injections, other interventional procedures. So we really, really try not to use them because we know kind of how dangerous those drugs are.
Yeah. And do you feel like that's how those drugs are viewed? And I know you kind of mentioned it, but viewed and used across the board?
Across my specialty or all medical specialties?
Um, let's say yeah, let's say both,
Okay,
yours
so
and all.
in my specialty, I think, I mean, the mentors that I've had in the field, I don't think I've seen them use those drugs, to my knowledge. Maybe they did, but that would be like a very, very like short-term type of thing, right? We're pretty against that as a medical specialty. Overall, and I think again, some of this is like based on like some of the historical data or some of the like basically the way like Purdue Pharma basically changed the landscape of things back in the early 2000s. But um, a lot of surgical procedures you're going to get opioids from, whether it's wisdom teeth. I had 2 shoulder surgeries, I think, and actually it's interesting depending on what state. When I had my first one in Iowa, they gave me 20 pills.
Hmm.
In Ohio, I actually had a lot. Where I had my second one, had a lot worse of an opioid problem. They gave me 60 pills after that surgery. I probably needed 4,
Four?
right? Yeah, that's it. 2 days, 2 days worth, and I would have been good.
And they gave you
Right.
60. What medicine was it?
I think it was Percocet. So it was
And your
it was
insurance pays for that?
Percocet. Yeah, no, insurance pays for it, and it's like $3, right? So I mean, nobody needs 60 of those after a routine shoulder surgery. Where like, and really, I would argue you don't need any. Like
Hmm.
acetaminophen, ibuprofen, whatever, that works good enough.
Yeah.
If you wanted to give a couple, I mean, that would have been fine just to get a couple days. But like after you get through a couple days of it, like you're in the most part on the way to a better path, pain wise. even like some of those wisdom teeth surgeries, they can be pretty nasty, but you should be fine in a week. Like no one needs a month of these things,
Right.
right? So people get a month of these things, and then they've been taking this every single day, and the bottle just says like as needed. But I mean, if people start liking these things, people start taking them, and then you get people that like become hooked, and all they did is go in for like a regular medical procedure. I
Right.
remember like when I had those 60 pills, I took like 4 of them, and I obviously couldn't really carry a backpack because I was in a shoulder sling. So I had someone on our team like drive me to class, and I had taken the pill like right before, and I just remember like looking up like the ceiling during class, like I couldn't focus on anything. Like my brain just like straight up wasn't working, and I'm like, I can't do this anymore. I just like got rid of the rest of them.
Yeah. Well, good for you. I mean, uh, that's insane to me that you got 60 of them. I think, I mean, that probably happens thousands of times every single day, and it's like, obviously there's something going on between those insurance companies and big pharma and the medical industry in some way. And I don't know if you can touch on what's going on behind the scenes on that, because I mean, from my perspective and my experience, it feels like a lot of this stuff is being pushed and being promoted to be pushed through maybe not the military, but definitely some of those, like you were saying, everyday doctors and stuff like that.
Yeah, so I mean, the insurance companies, if something is like approved by the FDA, like for a certain condition and it's available as a generic drug, like they're going to pay for it, right? So a
Right.
lot of these pain medications, they've been around long enough that they're generics, and so they're pretty cheap drugs. So like I would argue that's not really on the insurance company in that case, because the insurance company basically has to pay for like whatever is deemed medically necessary. I think the problem is that back in like the early 2000s, you had this push where like um, basically pain was supposed to be accepted as like another vital sign along with like heart rate, respiratory rate, temperature, which are obviously objective things. Like you can't fake your heart rate. Your heart rate is your heart rate, but pain
Right.
is extremely subjective, right? And even people that are experiencing the same thing, went through the same operation, have the exact same injury, someone will report a 10, someone will report a 2, right? It's so completely subjective. And so there was this push by some of the pharma companies to add this pain as like another vital sign. And if you have this hospitalized patients, like it became like a quality metric where they shouldn't be in pain.
Hmm.
And if your hospital is being evaluated on keeping patients out of pain, then what are you going to do? Use the strongest drug available to keep them out of pain, because otherwise your hospital is going to look bad.
That's interesting.
And your satisfaction scores are going down. People are going to think you're a bad doctor because that's what the reviews are going to say online, and whatever else you're looking at. So um, the system was basically duped into believing that like you needed to use these types of things. So people would be, if they were in pain and they were in like a post-surgical stay that lasted like weeks, they could have been on opioids the whole time. And when they come out, they're going to want more of that, right? You
Hmm.
can't have prolonged exposure to those things and not get into one of those situations. You can, but it's hard.
Yeah. I'm curious, what's the protocol if say you were to um subscribe is not the right word. My brain is broken. If you were to divvy out some pain medication and then that person comes back after they finish that and requests more after a period of time where that they should not be needing that anymore.
Yeah, so it depends on the state actually, which is why the problem is a lot worse in different states. But certain states, I believe Maryland has one, and I'm pretty sure Iowa does too. Haven't really dealt with this in any other states, but there's like a statewide system where you can track opioid prescriptions. So you can see like, did they get some from the ER? Did they get some from a different doctor? Are they going around to different doctors trying to get this?
Mm.
Um, like a responsible doctor would not give them more of that drug right away. And again, my argument would be like, if you're using it as a long-term treatment option and the patient's not like basically dying, you shouldn't be doing that, right?
Mm.
There's a way to treat their pain that's not involving that, right? Because again, like whenever you're dealing with something in medicine, the best thing to do is try and get to the root cause, right? Opioids don't get to the root cause of anything. They just mask the problem,
Mm.
right?
Yeah. I agree with you on that. It's kind of a band-aid thing. I kind of have a view on a
It's
lot
like a
of
band-aid
those
to a gunshot
control
wound,
drugs.
really.
What's
Yeah.
that?
It's like a band-aid to a gunshot wound. It's not going to solve the problem. It might make it look better for a little bit, but like
Right.
whatever's causing the pain is still there, right? So you're going to need more and more doses of it because your body's going to get tolerant, and hopefully you don't become addicted, but that's a reality to a lot of people.
Yeah. Well, segueing into the addiction thing, we do have every time we bring on a guest, we typically ask them, um, what is your understanding of an addict and alcoholic? And so I'll ask you that, and then I have a follow-up question to that for you.
I I think it's people that are like the first thing that comes to mind is that people who are trying to cope with something that's hasn't been dealt with properly. Again, like I kind of said earlier, like physical or mental. I think the first things that come to mind um, are people that like some family members I've had that have been like veterans or like service members that have like used a bunch of alcohol or types of things in order to like self-medicate for PTSD or even self-medicate for something like ADHD or something like that, right? They're just trying to treat something that's not being treated properly and it goes off the deep end, right? I think that a lot of them, most all of them are like well-meaning people that just kind of got dealt a bad hand, right? And so, I mean, they're good people, and you gotta do what you can to help get them out of that situation. I think that's why I've been reaching out to you, and I've had patients like that over the past couple of years, because you really you want to really like figure out how to get to the bottom of it.
Yeah. Thank you for that. Yeah, I think it is kind of a potentially dealt a bad case, bad hand, but I think there's also something that I'm really excited to get into grad school and get more educated on it all because at this point most of my knowledge is all experience based through interactions and the research that I've done myself. And I think, part of that is trying to figure out who I am, you know what I mean? And why
Right.
I am like I am. And I think it's kind of that nature nurture. You got trauma
Yeah.
experiences, you have all these things that go into it, and I'm a firm believer in the propensity idea that it's kind of like everyone kind of has a propensity, if you will, to be more or less addicted to this or that, and more or less addicted in general. That you hear people saying that addictive personality, um, and so I mean, I think it'll be interesting to see how the medical field develops when it comes to addiction, because from my personal experience, and I wonder if you can testify to this, is that in terms of like surgery or things like that, the medical field is like, in the Star Wars era. But when it comes to mental health and addiction understanding, it feels like that is still kind of lacking a little bit. How do you feel about that?
I think it is lacking, but I think it's actually it's improving. It's
Yes, for
improving.
sure. For sure.
We are making progress, but yeah, I do agree with you that um, it's not where it should be. But I really do think a lot of good strides have been made in the last couple of years.
Yeah,
Particularly one of the biggest ones that I've seen. You're probably familiar with like naloxone or Narcan, right?
I am.
That's right. So do you know what naltrexone is? It's like
I
a
did.
different, basically.
Yes.
So naltrexone basically just like long-acting Narcan. Um, yeah, so it can be used to like suppress opioids, but there's been a lot of research coming out lately that's actually really interesting, where naltrexone will actually suppress like addictive urges in the absence of opioids.
Mm,
So people have been using naltrexone for like you can use it for like to suppress cravings for like alcohol or cigarettes. But then even more interesting is that it's actually been effective to suppress things like binge eating disorder, like gambling addictions, things that have nothing to do with a particular substance because it's acting on those like endogenous pathways in the brain. Um, and so like I think that's a really, really interesting thing that's happening. Like you can use an anti-opioid drug for weight loss, right? Because it's treating the addiction to food. So, I mean, and that kind of stuff's in its infancy, but I'm really excited to see where this kind of plays out. Because I'm also really interested in like metabolic health, diabetes, that type of thing, and like trying to figure out how people that got into that bad lifestyle can get into a better one as well. So,
Right. Yeah, and it's interesting because that sort of thing is very interesting to me. Well, like, I've thought about, and when I was in inpatient rehab, there was talks of, like I wish there could be this pill that you could take that would take all of my cravings and everything away. I wish there could be some sort of medicine, this one magic pill that I could take where I wouldn't
whenever,
want that. And it sounds like potentially, something like that may be coming down the line. But I was in rehab in 2016, and that was the year, literally while I was in rehab, was when the general surgeon passed the designation that addiction was a disease. So we're talking 6 years ago is when we identified it as that. And I think that with a lot of things, it takes time. And along those lines, it's like there are some people that I don't want to say I'm not going to say need to die off, but like there's people that have a general understanding of it from an older generation that kind of potentially still see it as that, like they can't it's a maybe see it as a choice thing. Do you know what I'm trying to say? So
yeah, but I know you're a big believer in like personal responsibility when it comes to getting out of these things and owning it, and like, admitting that you have a problem and admitting that you're powerless. I listened to your podcast about the first three steps,
yeah.
talking about like the process of admitting that like you're powerless to like this drug, this substance, whatever. I don't think that we're ever going to get a magic pill that's going to take all of the cravings away. But what I think we can do is get something that can make those first couple of steps easier.
Mm.
I hope. I hope.
Yeah. I think the methadone and what you were mentioning there, those sort of things, I've struggled. And we had Emily on a couple episodes ago, and she previously worked at a methadone clinic. And I feel like even with the conversation with her and things like that, I struggle to fully, it's so weird because it's like, does it help? Yes, I think it does help in the intermediate. I think that the issue is, and a lot of it is a lack of funding. A thorough amount of funding needs to be put behind those sort of clinics because, she was talking about being how they were, semi understaffed, right? And over, have tons of people coming in. Her caseload was nuts. And if you're handing out drugs like that, like methadone, that is, technically continuing use, like there needs to be a plan to get off that. There needs to be, I mean, and there is a plan, but I heard of people being on methadone for 2 years. I was never a user of heroin or meth or any really quote unquote, your cliche hard drugs like that. And the most I got to was pill abuse along with some other stuff. So I can't speak to it from my personal experience, but from what I've learned and stuff, it feels like some of those clinics, if you drive to one, we talked about this a couple of days ago, you drive to one at 8 in the morning, you got a line around the block waiting to get their methadone. And that's always going to be a really interesting conversation to me, I think.
So I got a couple of things on that. So one, I mean, I agree with you about funding. I think again, like the biggest thing we can do to move this needle forward is just like research, right? There's so much more that we need to do in terms of like in terms of what we can do to help these people. And the problem is that like a lot of this research is being done by pharma.
Mm,
And so like there's not as much money in treating these things as there is in treating like chronic pain, right? If you're treating a chronic pain patient, you can get them on a drug like forever. That's like what the pharma companies want,
mm,
right? The other thing is something I want to ask you though, and so I know like a lot of your hesitation with methadone is that, I mean, methadone is an opiate, right? It
right.
is an addictive substance that's replacing another addictive substance. But what about a drug like naltrexone that is the opposite of an addictive substance. It's literally like blocking those receptors, and so you cannot become addicted on it. Do you feel differently about using like a pharmacologic intervention if there is no possibility that they can become addicted to it and actually it has the opposite effect?
Yeah. I mean, that sounds great. But um and I would lean more towards that than methadone for sure. And I think that that's a newer development. That came after methadone. Is that correct? Yeah. And so uh I personally need to do more research into that. But from what I've heard that it's so far been a pretty promising, a promising thing. And I completely agree. I think if we can move off those like obviously addictive things, where I know methadone is much quote unquote chiller, and has kind of like a steady thing, and you take it in the morning and it lasts you longer. Um,
Yeah.
but yeah, I mean, it's yeah, I don't know what to say to that. Really, it sounds better, and from what I've seen, it's better. But I won't lie to you. I when I got out of rehab initially, and this is part of one of the things, there was an addiction specialist there at the place that I was at, and he kind of lit me on fire in terms of he sat me down a couple days before I left. And an addiction specialist is what I aim to be at some point here. But he sat me down and he said, like, I'm not going to send you back with any antidepressants or anti anxiety medicine because I think you'll abuse it. He said, I'm not going to send you back with it's funny, bro. I mean, I'm an addict. And he was like, I'm not going to send you back. I had a Ritalin and an Adderall I don't know why I keep saying subscription.
Prescription.
Prescription. Yeah. Uh, prescription. I had an Adderall and Ritalin prescription. And he was like, and he said, I know you have those, but I would strongly advise you to not pick those back up when you leave because, I think that it'll be a challenge for you to take that medication in a directed way. And so I never took any ADD medicine, or Ritalin or Adderall ever again. And because of that conversation, and this is misguided, I fully understand that. I was very, and I'm embarrassed to say this, but very anti-medicine in general for a good amount of my recovery initially. I was, a little bit of that was ego, and it was like, I don't need anything. I'm going to do this all by myself. I don't want any antidepressants. I don't want any anti-anxiety. And to be honest with you, a lot of that early recovery was anxiety and depression ridden, but and I've moved off that. I've seen the benefits of the medicine, but I think that it is prescribed far too easily and fast. And a lot of it is, from my perspective, is eyes closed throwing a dart at a board in some respects when it comes to the medicine, seeing what works and what doesn't. And from my perspective and in my experience, I've seen that really fuck people up. And yeah, I want to hear what you have to think about in terms of when it comes to prescribing antidepressants, anxiety, and all that stuff, along with the hard drugs. That process of figuring out what this person may or may not benefit from, I wanted to learn a little bit more about that.
Yeah. So again, first of all, I'm not a psychiatrist,
Yeah,
but
I know you're
but
not. I think just from maybe what you conversations you've had to your understanding, because you're a very
yeah.
smart guy.
Um, So, I mean, I think it's really highly dependent on the specific drug that you're talking about, right? So when you're talking about opiates or even stimulants like Adderall, Ritalin, whatever, like those are addictive substances that you build up huge tolerance to over time. And you can run into some like pretty severe issues with those. But I think that things like most antidepressants and most anti-anxiety medications, there's a couple exceptions to that I can think of, but most of them aren't addictive and most of them are actually kind of work in a way where they have to like build up in your system over the course of like 6 weeks. So you
Right.
don't even like see anything for like 6 weeks. And that makes using them pretty difficult because um, like it's really impossible to tell which one is going to work for which person, if any of them are. And the reason for that, I mean, there's a bunch of different theories to like the reason for it. Like one I've heard is that there's like different people have different like genotypes for like different enzymes in their brain or whatever. And like maybe in the future you could do a gene test to see like could someone is going to respond better to this one versus this one.
Yeah.
Maybe that's like could happen in the future, maybe not. Um, but like these are the type of things that it's really just like trial and error, and then also like they all have like sort of side effects, and you're kind of just like optimizing for like which side
Plus
effects are
minus.
desirable versus not desirable, right? Like some of them have side effects that make you more alert, and you're like, okay, well, I struggle with like kind of low energy, so maybe that side effect is a good thing,
Mm.
right? So you kind of like have to think of all the side effects being like neutral, and then which ones you want, which ones you not want, and then with as far as like the using them for like people in recovery, I think, I mean, the approach that you took is obviously working, and I think that that can be a good like could be good for a lot of people, but then also like I feel like there would be people that would benefit from those and maybe without them would have turned back into using again, right?
Yeah.
So like I feel like if there's going to be a subset of people that are going to do better with them, and there's going to be a subset of people that are going to do better without them, like you. And I think that it's you really gonna need someone like really experienced to figure out like which kind of camp they fall into, right?
Yeah.
Because I don't want to take a black and white approach to it.
No, not at all. Definitely not. Yeah. I agree. That's what I was trying to say. I think that like when it comes to that
Oh,
medicine.
my wife downstairs, she just texted me. She said the gene test already exists.
Oh, really? That's hilarious. Um, yeah, I think that it's like, um, well, I guess I agree with you. I agree with you for sure. I wanted to ask you, like, because we're talking a little bit about this before we started recording the veteran situation. Now, are you going to be working with more veterans or active members, or is it a mix? Active
Mostly
serving.
active,
Yeah.
mostly active. Because I mean, I'm right now I'm reserve, but will be active duty when I graduate. And I'll be at an active duty hospital, so pretty much active duty. I've done a little bit of VA work um, in medical school, and then you do some rotations of the VA while you're here. But again, it's mostly active duty. The only exception is that like if you served a long time and you get retired, then you can sometimes go to the active duty hospitals like Walter Reed or whatever. So like retire after 20 years, and you have a condition that really can't be managed by the VA that needs like a better, higher level of care, such as like I think some of the like pain stuff we do, we will do those procedures on veterans, but it's really hard to get in unless you serve like for a really long time.
Yeah. What's your view on the on how the veterans are handled in this country?
I mean, I think it's not good. I think that there's, and I don't really understand the politics of why this is the case, but there's like a huge funding difference between that I've seen between the VA and between like the active duty hospitals.
Hmm.
Like when I've done my couple rotations at the VA, it's like hard to get anything paid for. It's like generic things only. They're not doing a lot of like more like state of the art type procedures. The facilities are older. The computer systems are like falling apart.
Hmm. It's interesting.
With that said, like I mean, the doctors of the VA. I remember when I was at the VA, I was like, you have all these things wrong with them, but the doctors were great. They were great teachers. I was learning so much. Like some of my best rotations were at the VA, and like I loved working with the veteran patients. Just like really connected with them. I mean, as someone who's like serving myself, comes from somewhat of a military family, I think it was a like a reward and an honor to be able to work with them. But then you go to some place like Walter Reed, or even more specifically, like when I was at Brooke Army Medical Center in Texas, like those were state of the art facilities that could do anything.
Hmm.
Like Brooke, BAMC, Brooke Army Medical Center, that's where they sent Alex Smith after he screwed up his leg.
Oh yeah.
And yeah, he had to have like permission from the president to go to like the best military rehab like center that they could send him to. We're putting like $1 million prosthetic limbs into like the amputee patients. I had this one patient that came in and was a double amputee from I don't remember exactly what happened to him, but he was like running marathons on these like $1 million legs, and he broke one of his $1 million legs running a marathon. And he just comes in, he's like, "Can we get another one?" And we're like, "Sure, here you go." Give him another one, right? So it's like you have so many, and like he deserves it, right?
Yeah, for
He deserves
sure.
to be able to run a marathon with his $1 million legs, right? So, and I mean, I wish we could give that type of care to all the veterans, not just like
Right.
people that are active duty. So, the fact that there is kind of a stark contrast between these two worlds, um, I don't like it, and I don't know what to do about it. But I really hope that we can get something figured out.
Yeah. Yeah, me too. I mean, I had never had too much previous experience with veterans through my own recovery. And if I did bump into them, they didn't let me know that they were veterans, in meetings or whatever. So I wasn't privy to that. But
They
through
did
my
or they
new,
did,
what's that?
did or they did not let you.
Did not,
Okay.
did not. Um, but through my new job, I have been working with veterans, and to see them interact with the VA and some of the things that they're going through and stuff like that has been frustrating from my position, because I'm in a helping position, and it does seem a little bit hard. I will say that the VA has seemed to help them a lot more recently. To my and this may be incorrect, but something happened in the last 6 months where they were allotted a lot of maybe it was in the last year, a lot more funding in terms of helping veterans get back on their feet from addiction and mental health issues.
Mhm.
And you're seeing a lot of them being fully funded into these treatment programs now, which apparently that's a new development, and that's amazing. I mean, our standard stay, or I won't say the standard stay in most treatment facilities when you're talking intensive inpatient is 30 days. And so for example, from what I've learned and seen, the VA is approving 90 days for these veterans, which is amazing. I mean, 90 days at a really good treatment center could, really change your life.
So
It
are you
really
seeing a
can.
lot of people getting those 90 days then?
From my understanding, they are approving a minimum of 90 days, which is amazing. I've never
So
heard. I mean, we're
you
talking
know,
a ton of money. What's that?
you know what the criteria is to get that?
I do not know exactly the criteria. I know that through some of the people that I've been working with, it varies across their experiences. But we have guys that have served in all different branches and had all different sorts of experiences in that. I don't think you necessarily, from what I'm seeing, it looks like they're pretty much
Uh,
green lighting a lot of it.
I mean criteria in terms of like what they're struggling with at the
Right.
time.
No, yeah, I understand. From um, I would say it's criteria what they're struggling with. Mental health and addiction issues, I'd say, across the board. I don't think that. Well, you know what? When I called in and went to rehab, I was told to call back and up my levels. So
What
I
do you
don't
mean?
know if something like that is going on
What do
there
you
or
mean?
not. Huh?
What do you mean up your levels?
So when I called in, my usage levels was I was drinking every day. I was using prescription drugs that were not prescribed to me. I was smoking every day, and the way it worked was you call basically this call center that is connected to through the company of whatever rehab you're going to. And
Okay.
I called in, and he told me what's going on. He said, "Tell me what's going on." So I told him my usage levels, and he said, "Hey, listen, Mitch, I'm going to need you to double what you just said for insurance purposes and call me back." So I hung up the phone. I called back to this hotline guy. We pretended to meet each other again. I doubled everything, everything I was using, and he said, "Fantastic, you've been approved. We're going to get you here today."
Wow.
Yeah,
So
that's a
that's
little
honestly
backdoor information into some of these places. Yeah.
That's wild. And also, like, if you hadn't had that back door, like, what could have happened, right? Because clearly you needed it.
Right.
Like, how many
Well,
people are slipping through the cracks because they don't have a back door like that?
yeah.
That's
Well,
what I'm thinking.
I mean, bro, that was 2016. There is I mean, we have, are you familiar with deficit focused documentation?
I'm not.
I would imagine, your wife is. It's like, or maybe yeah, I would imagine she is. It's kind of like when you're in a treatment center. I kind of threw some shade at the insurance company earlier, and this maybe you'll understand a little bit more now is because, from my perspective, some of those insurance companies kill people every single day,
Mhm.
to a degree. I'm trying not to use sweeping statements, but deficit focused documentation is when you're working in a treatment center or inpatient or outpatient, when you because we are in direct contact with insurance companies, if because most of the time they're paying a good amount of it. Um, the insurance companies get weekly or biweekly updates on their patients that they're paying for. And so if I go in and write, um, John had a great day. John's doing great in group. John was smiling and laughing all day. Said he had a great session. Said yada 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 yada. They might hop on and read the notes, and be like, check him out. He's done. Like, they want to stop pain as soon as possible. So
Mhm.
deficit focused documentation is going to be more focused on what they struggled with that day. Uh, what
Oh, so you're just like fibbing the insurance companies, basically.
was that?
Like fibbing the insurance companies for it.
Not necessarily fibbing. I think it's highlighting what they need to continue to work on, I think.
Yeah,
And yeah, but it's kind of trying to extend their stay or get them at least to those 30 days. I mean, how
right.
if you think about it, 30 days to change your life, you're still going, is it a long time? Kind of. Is it long enough? Probably not. And so to try to get all this shit done in 30 days, I had a friend there that got kicked out after 2 weeks,
Right. So
and
what do
he
you
he
think?
OD'd and died. So
What do you think? Like in an ideal world, what would it look like for you in terms of like the way that
a
the
treatment
system works
plan,
to help the most people? Yeah,
a treatment plan.
yeah.
Are we talking mental health inpatient or
So are you doing
an
inpatient right
addiction?
now?
What's
Is
that?
your current job inpatient?
It is, yeah.
Okay, so yeah, let's start there.
Okay, so if we're talking about a moderate to severe substance abuse disorder with a co-occurring condition of mental health as well, which I always see it as dual diagnosis co-occurring, uh, not always, but more 90% of the time, I'd say it starts with 30 days, like they said. But if we're talking ideal, I'd say 2 months. I'd say double that. I'd
Hmm.
say 60 days is pretty good. That's fair. It's a long time, but 60 days of intensive inpatient, I would say. Moving now, this is the big one. Okay.
Hmm.
After you leave the inpatient, because the inpatient is kind of like a haven, you literally live there. There's a lot of rules and regulations to keep you clean and sober while you're there. You have classes all day, counselors, everything. It's the step down and the aftercare that in a lot of places gets forgotten or not highlighted enough. So it's like, I think you go from that intensive inpatient 60 days, and I would say a month, 30 days minimum of intensive outpatient, which is a 9 to 5. You can stay at home or you can live in a sober living. Depending on the varying degree of the issue, I think that would be decided towards the discharge of the inpatient. But an outpatient program is pivotal, I think, because I think you need to get a little bit of taste of living in the real life back with that, same inpatient type of care from a 9 to 5 perspective.
So what did that step down look like when you were going through this?
So I was scheduled for 30 days, and then I talked to my therapist when it was getting close for me to discharge, and I was really nervous and scared about leaving. I didn't think I was ready yet, and she said, I'm going to try to get you some more time. And so I don't know what that ever looked like. Now that I'm kind of seeing it on the other side, maybe she wrote that I had a really bad day and got me an extra 5 days. So I ended up being there 35 days. And leading up to that, there's a lot of communication with staff as to what your aftercare is. And so they set me up with Yeah, they set me up with an outpatient program back in Ohio, whereas this inpatient was not affiliated with them, but they were in South Carolina. So it doesn't necessarily have to be within that rehabilitate or that treatment center's company, but they set me up with an outpatient. I took a plane back and had my first day of outpatient the day after. And it was a 9 to 5. My mom dropped me off, did that for the day and picked me up, and then I would stay at home. But I did 2 weeks. I did 35 days of inpatient and then 2 weeks of outpatient. And I never went to sober living.
So, if you saw yourself as a patient now, like how would you change the course that they took?
For me specifically,
Yeah, like if you let's say that you're running a rehab and you see a clone of yourself coming through, like what would you do for him?
oh man, bro, I was such a fiery bastard that it probably wouldn't have mattered. I bet if I met my literal self when I was in inpatient, probably would have spit on me or some shit, bro. Uh, I don't know. I'm joking, but I am serious. Like it is very, like you were highlighting too. And this is probably the hardest thing about everything that we're talking about when it comes to opioids, medicine, pain, all that shit. It's all so individualized
Mhm.
that there will never be someone that writes something down on one piece of paper that's like step 1, step 2, step 3, and you can apply that to everyone. And for that
Mhm.
reason, that's what makes it so hard. You know what I mean?
Yeah.
Yeah.
But I guess what I'm trying to ask is like what could they have done better when they were working with you, if anything?
Mm. Nothing. I'm grateful. I know this is a bullshit kind of cop out answer, but to be honest with you, it's true. There's not, I mean, I look back on those 35 days very longingly almost. Like it was so amazing for me. It changed my life truly. I had great counselors. I met great people there. That addiction specialist guy really touched me in a certain way. He's a
Mhm.
great guy. And even my outpatient was through Columbus Springs, which is in Dublin, Ohio. That program was amazing too. And no, I wouldn't have changed it. I wouldn't have changed it. I would have hoped that I was more willing. But all the classes and what I was taught have remained true to this day, you know,
Okay.
which is dope. But um, I did want to ask you in terms of coming in towards the end here, just like leading up to, you finishing your medical degree soon. We've kind of talked about this. How do you feel about how do you feel about like we kind of touched on it briefly in the morning, but you're going to be working with the pain and all that kind of thing. Where do you how do you think that's going to go for you, I guess is what I'm going to say. What do you envision like say, first day on the job, you got a guy coming in there and he's talking about this and he's like, I need yada yada yada. How does that look for you?
Like he comes into me asking for like opioids or something like that.
Something, yeah.
I mean, so usually, I mean, that's kind of a red flag that we're taught. Like, if you're coming in looking for something specific, then we really, really try and kind of look into the whole picture and figure out what's going on, right? Because if that's the first thing he says, I'm like, okay, so like, what's hurting? How is this? Or like, what happened? How long has this been going on? What else have
Yeah.
you tried for it? Have you tried physical therapy? Have you tried like bracing? Have you tried stretches? Have you tried injections? Like there's a million different things you could try for. And I'm like, so why are you like fixated on this one specific thing?
Right.
Um, because again, like what we talked about earlier, it's about getting to the root of the problem. Um, so like I think it'd be irresponsible to just like go straight to like, oh yeah, like I mean if you've never seen the patient before, you can't just like take at the word that they've tried everything else. You got to like do your own evaluation, right?
Yeah.
Um, Now like maybe every now and then like this patient has seen like one of your like partners or whatever, and like you can look in the notes and be like, okay, like they've seen like they actually have done these things, and this is some sort of agreed upon treatment plan. But if I don't see something like that, um, I'm gonna do like a really thorough evaluation, and I mean, chances are like the patient that's coming in asking for those things has probably not done the like A through steps that
Yeah.
you would need to do to get to before you got to that point.
Yeah.
So I would just kind of back up and be like, I don't feel comfortable doing this, and I don't really want to prescribe a drug like that. But here's what I can do for you, and then just kind of list out, kind of what a treatment plan would be for that specific condition.
Yeah. Yeah. I think that's a good way to go about it. I think I was going to ask you, this might get you promoted all the way to the top if you get it right. In terms of the opioid crisis, what do you think the solution is? Obviously, it's multifaceted, but if you could pick like a couple things that could help a lot, what would that be?
I think that like the narrative in like medicine in the hospital can be like needs to change so that it's okay to be in pain sometimes. That's one thing, right?
Okay.
So like embracing a certain level of pain as being normal, right? Like all of human history, people have been in pain,
Yeah.
right? And you deal with it, right? But I don't want people dealing with it chronically. I mean, that's kind of my job is to treat it, but sometimes it's inevitable, right? And if your body just got cut open for surgery or something, you're gonna be in pain, right? So I think embracing some level of it, I think would be a good thing. I think shorter courses of opioids when you use them. Again, like I said with the shoulder surgery example, like I needed 4 pills, right? If you gave them 10 instead of 60, there's a lot lower chance that they would become addicted to it.
Right.
I think 60 could be enough, probably. I think that this is kind of just a problem that I've seen with just kind of like the relationship between the government and the drug companies in general. But I think that, and I don't know exactly what the solution this is, but there's when drug companies like do their studies trying to get something approved, a lot of times like they'll just like do their own studies. And so when you do your own study and you control every aspect of it, it's really hard to kind of like rig it into looking like something you want. And so it's really easy to like find an outcome where, this drug is showing this effect, but, you have to look into things like, what are you comparing this drug to? So like a good example of this is like coming out, a lot of different cancer drugs that are coming out nowadays. It'll be like this drug is like 60% better than the competition or whatever. But then you look in the fine print and it's like the competition is like notified as some drug that came out 40 years ago, not the one that came out 3 years ago. So it's like, yeah, of course it's 60% better. If you compared it to the one that came out 3 years ago, is it going to be the same? Maybe it's the same, maybe it's better, maybe it's worse. You don't know.
Yeah.
But like that type of study can just prove, you don't have to prove that it's better than anything that's ever existed. You just have to prove that it like works to a certain degrry.
Helps, right?
I think like changing the whole like narrative around the way we do research in medicine would be really, really good, because you couldn't really get something like, just like a long-term opioid use approved.
Yeah. Right.
Right. Because I mean, OxyContin never should have been approved for long-term use.
Definitely.
That was the whole thing. That was the whole thing, was that it was approved for long-term use for like not even that like moderate pain, basically.
Yeah.
Right. And then so again, if you change the narrative that like some moderate level of pain's okay, then that could help. And then a lot of the interventional procedures that like my specialty in medicine does, if the person came in for low back pain 15 years ago, if they went to a physician that was not experienced in treating that type of pain, then they may have been just given a pill rather than something that's actually targeted to treat their condition. And I actually had this experience. I was rotating with a physician, not military affiliated, here in Maryland a few months ago. He was a smart doctor, but he just was not really well trained in the musculoskeletal system, joints, the nervous system, stuff that I am well trained in. For a medical student, I mean, there's people way better than me, but we're still working on it. But anyway, people would come in with like back pain, hip pain, knee pain, and this was like day 2 of the rotation. Someone comes in with with back pain, and he just like doesn't even really like look at them, and he's just like, "Oh yeah, I'll just like give you a drug." And I'm like, "You didn't even look at that guy. You didn't do a physical exam. You didn't evaluate him, and all of a sudden you're just like giving him like this pill." And I'm like, I was literally like, "Let me take care of this." So I go back in the room. I do an evaluation on him. I come up with a diagnosis, and I'm like, here's what you need to do. And he's like, was kind of struck by the fact that I like knew enough to do that right now. And I'm like, you don't need to give him that pill. You just need to do this, and he'll be fine. And we did it, and the guy was fine, right? And so that
Damn,
the
that's
rest of
crazy.
that rotation, I just saw all those patients for that doctor,
No way.
and, and yeah, I just like saw all of his like pain and MSK patients, and then
That's
some of them were like asking for follow ups with me instead of the guy I was working for. It's kind of fun. But then I'm like, yeah, if I hadn't been there, he just like would have been handing out pills. Not because he was like trying to harm the patients. Like he was a very well-intentioned guy, but he just was not trained in this. He was
Mm,
trained 40 years ago when we didn't know any of this stuff, and he wasn't like continuing his education in a way that
mm,
would be conducive to learning this stuff. And I mean, when you're an internal medicine doctor, you're more focused on things like diabetes, blood pressure, et cetera, et cetera. So like, it's not really his fault for not looking at that stuff, but you need to know what you know and what you don't know. And
right.
if you don't know something, you need to be able to refer to someone who does know what they're doing.
Yeah. Amen to that. And thankfully you were there. That's wild. You just stepped in and be like, I got this, brother. That's amazing. Yeah. Yeah, that's what worries me, man. Is like how much does that happen all the time? How
It
much does
happens,
someone just end up with a bottle of 60 Percocets? You know what I mean? Like I
it happens every
it's
day, multiple times every day.
it's the biggest issue in the country by far in my perspective. If you put mental health and addiction together, I think nothing even really comes close to that if you're talking about the well-being of everyone. So
Yeah, I completely agree with you.
it's yeah, it's very concerning. And I appreciate you helping how you do, and for your service in general and for your service in that way. I really do.
Thank you.
Yeah. And yeah, I was gonna say, do you have anything else that you wanted to speak on today?
Yeah, I don't think so. I think I pretty much got all of it.
Got it all? Yeah. That was awesome. We covered a lot. I mean, I've always looked at you as like so fucking much smarter and brilliant when it to me and on most people. So that was awesome to hear your perspective on all that, and I'd love to have you back on at some point. And when we have everything on Spotify and Apple Music, as we were joking
Yeah.
about before, say a prayer for me on that. I still gotta get that done. I think I remember saying like before episode 10, I was like, we will 100% have it before episode 10. But life kind of took hold, so it'll get
Understandable.
there. It'll get there. But thank you again. Extremely grateful for you to have you in my life as a friend, and as as someone I can talk to on a pretty high level when it comes to this stuff. And
Of
maybe we could
course.
get your wife on here at some point. That'd be sick. Congratulations on getting married, by the way. That's nuts. I feel like that
Thank you.
that that moved fast, didn't it?
Yeah.
Yeah, that's awesome.
Yeah. The military, like everyone here is married.
That's awesome. Well, as long as you guys are happy.
We're very happy.
Yeah, I love to hear that. All right, brother. Well, thank you so much. And to everyone that's listening, this is episode 22 with Peyton Gaumer. Um, keep coming back, and we will see you on the next one. Thank you, Peyton.
Good to be here. See ya.